everyone, my name is Sticky Stallworth and welcome to my presentation on clinical outcomes assessment in practice. Today's presentation will be based on a true story. We're going to discuss a 24-year-old right-hand dominant male who is a former competitive pole vaulter. This patient has a past medical history of repeated shoulder subluxations. In 2010, our patient underwent anterior arthroscopic capsule labral repair and then subsequently performed 8 months of physical therapy before returning to sport. After approximately 12 months of pole vaulting activities, the patient noticed that subluxations began to reoccur on a regular basis. At that time, in 2013, the patient elected to have open surgical repair to regain the stability within the right shoulder. After the repair, the patient completed 4 months of conservative physical therapy in his home country of Jamaica, at which that time he discontinued so that he could pursue his college education in the United States. At the time he came to me for clinical evaluation, the patient reported no complaints of pain, only sticky and itchy sensations in the posterior shoulder located over the medial border of the scapula. There was no tenderness to palpation, no visible signs of swelling or ecchymosis, just significant complaints of crepitus within the glenohumeral joint, specifically with internal rotation or extension of the humerus. Passive and active range of motion was limited in overhead activity, especially in the directions of flexion, abduction, and external rotation. The patient also complained of some discomfort with horizontal adduction as well as external rotation, and he had some scapular dyskinesis whenever he tried to elevate the humerus. Atrophy was present both in the anterior pectoral muscles as well as posteriorly in all of the musculature. His strength was limited due to his range of motion deficits. The patient's primary complaints were moderate difficulty performing activities of daily living, such as washing his back, putting on a shirt, or sleeping with his arms overhead on his stomach at night. To go back to some of the information we learned earlier in the fall block, we'll discuss disablement models. The World Health Organization International Classification of Functioning Model, aka the ICF, can be used to describe the disease process and how it affects the individual and the way he interacts with his environment, in a universal method that us clinicians can understand. Our diagnosis for this patient is going to be shoulder adhesive capsulitis, and we can code this in a variety of ways. First, in regards to body structures and functions, we can use a code of S720 for joints of the shoulder region, as well as B7101.2 for moderate impairment and mobility for several joints. That's going to refer to the glenohumeral joint as well as the scapula. We can also code this for activity impairments. We'll use a code of D445 for impairment of the hand or arm use, D510 for impairment of washing oneself, and D540 for impairment of dressing. Additionally, we can have qualifiers of 2 for moderate deficiency, and we'll use this because our patient cannot reach behind his back or overhead without problem. You'll notice in here that we did not use our participation code, and this will be because at this time the patient has decided that he no longer wants to participate in pole vaulting activities due to injury. In order to measure the patient's progress during rehabilitation, we'll have to select an instrument to compare these patient-oriented outcomes. Because the patient in this scenario has minimal pain, the instrument we select will look to investigate changes in functional limitations. According to the most current research, we will select to compare the disabilities of the arm, shoulder, and hand, as well as the Pennsylvania Shoulder Score. We'll suggest that these are 2 of the best available instruments to measure satisfaction as well as the patient's status throughout the course of rehabilitation. The DASH score is a 30-item, region-specific self-report measure designed to evaluate arm, shoulder, and hand conditions based on the perceived ability of patients to perform activities of daily living or sport tasks over the course of the preceding week. The DASH score was developed by the American Academy of Orthopedics orthopedic surgeons in conjunction with the Institute for Work and Health to measure limb functioning as a whole and not as a sum of the parts and as a whole. This measure is scored on a scale of 0 to 100, with higher scores indicating higher levels of disability. The dash can be completed in as fast as 6 minutes, with a quick dash version resulting in even lesser completion times. To make some comparisons about the dash, authors Beaton et al. Has shown that the dash is both reliable and valid as an instrument. Additionally, Gooseman et al. Reported that the dash instrument is responsive in detecting small and large changes in disability over time. Numerical results of the dash are easy to understand for both the clinician and the patient. Interpretability is increased due to the literature reporting minimal detectable change percentages. Again, the dash is quick to complete and it's available in multiple languages to help with patient acceptability as well as clinician feasibility, particularly here in Miami where we are extremely culturally diverse. The dash is also considered a public domain, which increases accessibility and allows for easy administration as well as decreased administrative burden. On the other hand, the Pennsylvania Shoulder Score is a 20-item, condition-specific self-report measure composed of 3 subscales. These 3 subscales are designed to measure pain, satisfaction, and function in patients with general shoulder pathology. This scale is also scored on a 100-point scale, in which this case, 100 points indicates high function, low pain, and satisfaction within the function of the shoulder. The Pennsylvania Shoulder Score takes as little as 10 minutes to complete and 2 minutes to score, and is appropriate for our case scenario because it has the ability to measure pain associated with different levels of function, as well as the patient's satisfaction with his current level of shoulder function, using separate numeric rating scales. Some pros of the Pennsylvania Shoulder Score include the short completion time, which increases patient acceptability and clinician feasibility. Also, the interpretability of the Pennsylvania Shoulder Score can be simplified using those documented minimal detectable change scores. Conversely, the validity and responsiveness of the Pennsylvania Shoulder Score have not been adequately assessed in research. In this scenario, we're looking to measure small to moderate changes in the patient's functional status. We know that he has adhesive capsulitis, so we anticipate that small changes will occur over a long period of time. Because the DASH instrument has proven to be highly responsive, with that being said, we will pick this instrument for this scenario. Goals and achievements. So me as the clinician and the patient have sat down to establish some goals for his rehabilitation. The patient hopes to achieve pain-free range of motion within 9 months of beginning consistent athletic rehabilitation. Additionally, the patient hopes to gain overhead strength that is equal to the contralateral limb. In order to determine whether the changes shown in the instrument relate to meaningful improvements in the patient's functional status, the clinician must be able to interpret change values obtained from the instrument. In order to interpret this, we want to look at both the error and the responsiveness of the DASH instrument. In particular, error refers to the reliability of the instrument, while responsiveness answers the question of whether the measurement system can capture valid and meaningful change over time. When establishing whether the instrument is considered a reliable measure, clinicians should look at both the standard error of measurement as well as the minimal detectable change value. The standard error of measurement refers to the error associated with one single measurement or the initial measurement that we take for the patient. To refer back to a study by Gooseman et al., he looked at various measures of validity for the DASH instrument, and upon his calculations, found a 95% confidence interval. What this means, I, as a clinician, can feel 95% confident that the results obtained from the DASH instrument are not due to error, and that they are really true, meaningful results. This information gives information on the reliability of the DASH instrument, but it does not give us information about the meaningfulness of this change. In order to establish the meaningfulness of this change, clinicians should calculate the instrument's responsiveness through both distribution and anchor-based methods. Distribution methods include measurements of statistics such as effect size and standard deviation. The DASH instrument has been reported to have a good standardized response mean of approximately 1.2, as well as a large effect size of 0.8. These factors provide evidence about the change, but they're not indicators of meaningful results. In order to determine the meaningfulness of these results, we'll take a look at anchor-based measurements. Minimally clinically important difference is one of the most common values of anchor-based responsiveness, and this refers to the smallest difference in instrument scores that is perceived as beneficial to patients. This may also indicate a value that is perceived important enough for a clinician such as myself to make a change in regards to the patient's care. Guzman et al. Suggests that a 10-point difference in DASH scores over time represents this minimally important change. Going back to our patient's initial evaluation, if he were to complete the DASH score, we'd anticipate him to have a score of approximately 47 due to his functional limitations. As we mentioned, with a case of adhesive capsulitis, we expect the patient to have small increases over a longer period of time. With that being said, we plan to repeat the DASH instrument every 2 weeks or approximately 6 visits, depending on scheduling. DASH scores will need to increase by a minimum of 10 points in order to be shown clinically meaningful. So, with that being said, we have set a goal of a minimum of an 11-point difference per month. If this improvement of 11 points is not achieved or a deterioration based on the DASH instrument occurs on monthly assessments, we'll modify the treatment methods that we're using, or we'll consult with the treating physician to consider a manipulation under anesthesia procedure. So in conclusion, we want to talk about how we would implement these measures into my current clinical practice. Right now, we function as athletic rehabilitation services at FIU. Athletic rehabilitation services is ran solely by one athletic trainer, myself, that is overseen by a medical director. All patients at the clinic are provided with 45-minute appointments that consist of either an initial evaluation and subsequent treatment, or a follow-up treatment and evaluation session, or follow-up treatment and rehabilitation session. The injuries that we see range from preventive care to acute care to post-operative care to long-term rehabilitation. All injuries and treatments and rehabilitations are documented using an electronic medical record. What are the benefits to implementation? Implementation of patient-oriented outcome measures can provide benefits to me as a clinician, as well as our patients and the administration who oversees the services provided within the student health services complex. These benefits include, but are not limited to, examining the progress and outcomes of the patient rehabilitation, documenting the effectiveness of specific treatment interventions, and securing funding through demonstrating the value of clinical athletic training services. This one is particularly important since our service is new and we need to establish the effectiveness of our services. In addition, we can answer clinical questions related to traditional research. Since one clinician is providing services for a variety of injuries, a patient-centered approach would be ideal in this situation. In this method, a clinician can decide which measure is most appropriate for each patient as we go. Type of measurements. The easiest and most basic method of implementation would involve distributing generic outcome measures to all patients seeking acute and chronic rehabilitation at their time of initial evaluation. Alternatively, we could consider using a region-specific instrument that is pre-selected based on the patient's primary complaint in efforts to make the treatments more patient-centered. For example, all patients seeking a shoulder evaluation would complete the DASH instrument. Frequency of administration. All patients receiving outcome measures will ideally receive outcome measures at the initial evaluation and at the final rehabilitation session. Patients with longer rehabs will receive follow-up interventions and assessments at time-dependent, such as weekly, bi-weekly, or monthly, or visit-dependent every 2, 4, or maybe 6 sessions, depending on their prescribed rehabilitation goals. Anytime we're implementing something new into the culture, there will always be barriers. In the research, as well as in my clinical practice, time is one of the biggest barriers. Aside from the initial time it takes to select the most appropriate instrument, patient completion slows down the visit and takes away from the time that I can dedicate as a clinician to provide treatment and rehabilitation to my patient. What are some solutions to this? Possibly, we can have generic measures loaded into the patient's student health portal and require them to be completed at the time of appointment confirmation, meaning these would be completed before they come to the visit. Secondly, we can have the receptionist at the front desk distribute these generic measures when the patients are in the waiting room filling out other paperwork prior to their initial visit. For patients with longer rehabilitations, we may be able to have them complete these measures while they're receiving their warm-up treatment, such as when they're on a hot pack or on the electrical stimulation prior to beginning more rigorous rehabilitation. The NIH Collaboratory recommends that selecting instruments that are limited to a 10 to 15 minute completion time in efforts to reduce burden on clinicians as well as patients. Secondly, also documented in the literature, is the barrier of lack of sufficient support staff. Because at Athletic Rehabilitation Services, we're run by a single athletic trainer, it can be difficult for me as a clinician to administer the instrument, score the instrument, discuss the instrument's results with the patient, and then continue to facilitate treatment and rehabilitation, all during one session. How do we solve this problem? The NIH Collaboratory suggests that embedding instruments into routine care is crucial. If the data is viewed as integral to the patient care and completing the instrument leads to tangible benefits, the instrument is more likely to be viewed as part of the culture rather than a burden to the staff. With this being said, education is key. We want to look to educate our receptionists as well as our medical assistants who work outside of athletic rehab on the goals and the purposes of patient-rated outcome measures so that they may be able to administer these instruments to the patients prior to our visit. In addition, we look to educate our graduate athletic training students who work within the clinic. They can be educated on scoring these instruments so that they can possibly expedite the assessment of the data obtained. With this being said, I'd like to thank my classmates. I look forward to your questions as well as commentary from our professors. I struggled somewhat throughout this course, and it feels very good to put the information together and to apply it to my clinical practice. Thank you.